Upper gastrointestinal bleeding remains a high mortality medical emergency, but the specific protocols for managing it have shifted significantly. Data collected between 2019 and 2024 shows that several historical stabilization tactics, once standard in the ER, failed to improve patient outcomes. We are mapping the definitive consensus guidelines for managing these bleeds. This pathway tracks the exact sequence required for patient survival, starting with pre-endoscopic resuscitation and concluding with long-term secondary prophylaxis. Effective management relies on the objective decision tree. Every treatment decision is driven by validated risk scores, hemodynamic data, and precise anatomical morphology. Clinical success is found in the rigid, step-by-step execution of this algorithmic model. The process begins in the emergency department with immediate risk stratification using the Glasgow-Blatchford Score. Patients scoring 1 or less are discharged for outpatient endoscopy. All others require immediate hospitalization and move to hemodynamic resuscitation. During resuscitation, we apply a restrictive transfusion strategy. The absolute trigger to transfuse red blood cells is a hemoglobin level of less than 7 grams per deciliter. This restrictive 7-gram threshold replaced the traditional 10-gram target because it resulted in improved mortality and lower rebleeding rates. Providers must avoid specific interventions that the evidence has disqualified. Do not administer tranexamic acid for an upper GI bleed, as it provides no clinical benefit. For cardiovascular patients on low-dose aspirin, the guideline is clear: do not stop the medication upon presentation. In these cases, the risk of a major cardiovascular event is higher than the localized risk of continued gastrointestinal bleeding. If aspirin was discontinued by mistake, it must be restarted within 3 to 5 days. Pre-endoscopic care requires targeted, evidence-based stabilization while actively avoiding interventions that have been proven ineffective. This is the major bifurcation. Management strategies differ fundamentally depending on whether the hemorrhage is driven by arterial ulcerative bleeding or venous portal hypertension. The algorithm splits based on cirrhosis status. For non-variceal cases, immediately initiate high-dose IV proton pump inhibitors and IV erythromycin. For variceal cases, start vasoactive drugs for 2 to 5 days alongside prophylactic IV antibiotics. Vasoactive drugs should never be used in non-variceal cases. They are contraindicated and provide no hemostatic value outside of portal hypertension. Survival during this window depends on matching the drug regimen to the specific vascular etiology. Both branches converge at endoscopy, performed within 24 hours. Data shows that for stable, non-variceal patients, rushing to urgent endoscopy offers no benefit over performing the procedure the next morning. Urgent scoping within 12 hours is only required in cases of hemodynamic instability or suspected variceal bleeds. For non-variceal ulcers, the intervention is dictated by the Forrest classification of the lesion's morphology. Actively bleeding ulcers, categorized as Forrest 1A or 1B, require combination therapy. Epinephrine injection alone is insufficient. It must always be paired with a second modality, such as mechanical clips or thermal contact. For a non-bleeding visible vessel, Forrest 2A, monotherapy or combination therapy is acceptable. For an adherent clot, Forrest 2B, the clot is removed endoscopically to allow for treatment of the underlying lesion. On the variceal track, endoscopic variceal ligation is the first-line therapy. Sclerotherapy is reserved for cases where ligation is not feasible or fails. Success in the suite is the result of precise morphological classification and multimodal intervention. Even with high-quality primary intervention, some patients experience recurrent bleeding. The algorithm provides subloops for these scenarios. For non-variceal failures, attempt a repeat endoscopic therapy first. During these repeat sessions, physicians may use over-the-scope clips or TC325 hemostatic powder spray to stabilize the lesion. It is important to note that TC325 powder is a temporizing bridge only. It is not recommended as a primary or single-agent hemostatic therapy. In severe variceal failures, a Sangstacken Blackmore tube can be deployed, providing physical tamponade for a maximum of 24 hours. This leads to the definitive variceal rescue, a TIPS procedure performed within 72 hours. For non-variceal failures that persist after a second scope, the protocol has shifted towards transcatheter angiographic embolization. Interventional radiology has largely replaced surgery as the second-line therapy. Open surgery is now an absolute last resort, reserved for cases where embolization is unavailable. As the acute phase concludes, we move into the inpatient recovery protocols for patients who presented with high-risk stigmata. High-risk non-variceal patients require an 80 mg IV PPI bolus, followed by an 8 mg per hour continuous infusion for 72 hours. During this window, H2 receptor antagonists should not be used, as they are clinically inferior to proton pump inhibitors for preventing rebleeding. Any patient who received hemostasis for high-risk stigmata must remain hospitalized for at least 72 hours of monitoring. The final stage of the pathway involves implementing secondary prevention measures to ensure the patient remains stable after discharge. All peptic ulcer patients must be tested for H. pylori. If the initial test is negative during the acute bleed, it must be repeated later, as acute phase testing can be falsely negative. Anticoagulation should be resumed within 7 days of hemostasis. Direct oral anticoagulants are typically preferred over warfarin due to their rapid onset. Patients on ongoing antiplatelet or anticoagulant therapy should receive daily PPI co-therapy. If NSAIDs are unavoidable, a COX-2 inhibitor must be paired with a PPI. Endoscopic hemostasis is only the midpoint of this process. Long-term success is achieved by following the entire evidence-based pathway from the moment the patient enters the hospital to their